Good morning, my name is Adriana Cabezas Cobo. I'm going to talk about point of care warfarin monitoring in the Rocket AF trial. In the rivaroxaban once daily oral direct factor XA inhibition compared with vitamin K antagonism for prevention of stroke and embolism trial in atrial fibrillation. Investigators found that rivaroxaban was non-inferior to warfarin in the prevention of stroke and systemic embolism in patients with atrial fibrillation. In December 2014, 4 years after completion of the trial, the Food and Drug Administration issued a recall notice for a medical device correction of the Alere NIN radio monitor system. The recall correction notice was issued because the FDA approved an European conformity marked whole blood point-of-care device may provide an international normalized radio result that is lower than an automated plasma-based laboratory INR in patients with 13 specific medical conditions. These conditions include abnormal hematocrit levels, conditions associated with raised fibrinogen levels, and bleeding or unusual bruising. In this table, we see the classification of patients for primary and sensitive analysis. Then, in October 2015, the Rocket AF Executive Committee was notified that the device that was used in the trial was included in this FDA recall correction notice. To understand the effects of possible device malfunction leading to lower INR values and inappropriately high doses of warfarin and bleeding, we conduct a series of post-hoc analyses of the Rocket AF data. Two physicians who were aware of study groups' assessments reviewed baseline medical history and adverse events identified during trial follow-up for all patients enrolled in the trial for any of the conditions cited in the recall. The table S2 is a summary of the conditions by warfarin versus rivaroxaban. Patients with central laboratory evidence of hematocrit values of less than 30% or more than 55% were also identified. We categorized the entire trial populations according to whether patients have had any recall conditions or no recall conditions, and then compare efficacy and safety outcomes of patients receiving rivaroxaban with those receiving warfarin within these subgroups. In the primary analysis, we compare the relative effects of rivaroxaban versus warfarin on measured efficacy and safety outcomes in the overall trial populations and in patients with no recall conditions. In a subsequent analysis, we compare the relative effects of rivaroxaban versus warfarin on measured efficacy and safety outcomes in patients with any recall conditions. We also performed a sensitivity analysis in which patients with possible acute onset recall conditions were included in the subgroup of patients with no recall conditions until the time of onset of the acute conditions. In addition, we evaluate the primary efficacy endpoint in the intentions to treat and per protocol populations to present results consistent with those in the primary trial report. Of the total safety populations of 14,236 patients, 63% had no recall conditions and the 37% had a recall conditions. Both types of patients were equally distributed between the warfarin and rivaroxaban groups. Patients without recall conditions were younger than those with recall conditions, 72 years versus 74 years, and were more likely to have a history of stroke or transient ischemic attack, less likely to have diabetes, and less likely to have been treated with a vitamin K antagonism before study entry. The characteristics of the patients were similar in the rivaroxaban group and the warfarin group in the subgroups with and without recall conditions. These results are consistent with those of the overall trial populations in showing the non-inferiority of rivaroxaban versus warfarin for preventing stroke and systemic embolism, with similar rates of overall bleeding and lower rates of fatal and intracranial bleeding among patients treated with rivaroxaban, but a higher rate of gastrointestinal bleeding. Among patients with any recall conditions, the bleeding rate was higher in both the rivaroxaban and warfarin groups. Furthermore, among patients with any recall conditions, there was a trend toward a higher relative risk of major bleeding with rivaroxaban than with warfarin, a trend that was not seen among patients with no recall conditions. This finding does not support the hypothesis that device malfunction led to an increased risk of bleeding in the warfarin group of the trial. These results are consistent with the overall trial findings and indicate that possible malfunction of the point-of-care device used for INR measurement in the ROCKET-AF trial that potentially leads to lower INR values than would be obtained by laboratory testing did not have any significant clinical effects on the primary efficacy and safety outcomes in the trial.